Good afternoon, everybody. I hope you're enjoying lunch. Looks very good. Somebody saved me a cookie. So my name is Ari Brooks. I'm a surgical oncologist at the University of Pennsylvania in Philadelphia, United States. And I will be moderating a little discussion. We're going to change things up a little and build. I don't know if any of you were in the last session in this room, but we're going to build on some of those types of sessions. It's going to be very data unheavy and more discussion and storytelling, a little bit kind of front lines or grassroots. The last session I really enjoyed. They were talking about what we can do with policy, what we can do with organized medicine, what we can do with the resources that we do or don't have, and how to leverage those to do better for our patients. And I think that's excellent. This session, I think we're going to talk a little bit more about what's actually going on the ground. We will talk about disparities in the U.S. a little bit, and we have an expert on that on our panel as well. And I think it's really great seeing some of the talks today to talk about what's going on in the United States. But I think, of course, it's really important to talk about what's going on the ground in some of our LMIC partners around the world, and what are some things we can do to improve access to screening and care. This is a sponsored session. The sponsor is UE Life Sciences. If you haven't heard of UE Life Sciences, you will. They are a platform for what I would consider population navigation. So we don't call them patients until they're diagnosed, right? But if there is a population that needs to be exposed to some screening opportunities or to be navigated through the screening and diagnostic pathway, UE Life Sciences is in that market and does a lot of it with a cell phone, which is pretty cool, and really specializes in portable frontline diagnostics. And so I think you're going to hear about one of their devices today. And so since it's a sponsored session, I have to disclose that I am on the medical advisory board of UE Life Sciences. So there you go. Our other speakers, Dr. Baskis is also on the medical advisory board. And our other speakers are actually nothing to disclose. So I'm going to invite actually our speakers up. Sorry, I'm going to put them back here. Dr. Murali, you want to come on up to the to our stand there? And he's Managing Director, National Cancer Society of Malaysia. And then Jyoti Patel, come on up. She's our nurse manager at Tata Memorial Hospital. Gave us an unbelievable talk yesterday. I don't know if you guys got a chance to see her speak about what she's doing as far as training and navigation, clinical breast examination in and around Mumbai. And I think it's I'm so excited to hear her tell us what she's been up to. And Maima Carmel, come on up. She's from the United States, one of my partners, and she's the CEO of the Tiger Lily Foundation. I'll ask her in a moment to tell us a little bit about that and why she did it and what she's doing. But also we're going to lean on her a little bit to talk about disparities in the U.S. So that's where we're at. And I'm going to also have by video Dr. Arnie Baskis, actually a neighbor of mine in New Jersey, but he trained in surgical oncology at the NIH in the early 70s. So he is one of the grandfathers of surgical oncology training in the United States. Has had a long and distinguished career with the American Cancer Society and also with the Commission on Cancer in the United States. And that, for those who don't know, Commission on Cancer certifies cancer centers and cancer treatment programs around the United States. And so that's another role that he has. So he was unable to join us, so we got some video of him answering some of our questions today. That's probably the most I'm going to talk. So now we're going to hear from our panel. And the first question that I'm going to ask, and I'm actually going to answer it too with Dr. Baskis first, but then we're going to go to everybody else. How do we do early detection of breast cancer? And we're going to start with the USA, and he's going to talk a little bit about disparities. Let's see if this works.
I've been taking care of this disease process since 1975. Right, it's a long time. And nothing would give me greater satisfaction to be able to prevent the disease altogether. And what we need to do as a country and as a world is to take late stage disease and move it in the other direction.
Downstage it.
Downstage it, exactly. A black woman in the United States today, unfortunately, is 40% more likely to die of her breast cancer than a white woman is. Your zip code shouldn't be more important than your genetic code is. We know there's data that shows that mammograms don't identify every breast tumor, every breast lump. There's lots of data to that effect. We know that, for instance, something simple like clinical breast examination can be valuable, and yet we're not using it enough. And at the same time, we know that there's data that shows that there's a 30% improvement in survival for women who are routinely screened by somebody who knows how to do a clinical breast examination. Teaching a clinical breast examination is a problem for the layperson, and a lot of professionals aren't comfortable doing it. So if we had a tool available that was simple and easy to use, wouldn't we be able to make more progress and make it faster? And that's really what we should be talking about, is how do we get good examinations, good screening, good things that we can use that are technically easy to use, that can make a difference for everyone. I would want something that could detect something in my body using a tool that would be simple to use and easy to understand, and be able to transmit that information to the healthcare provider of my choice. I would want something that was cost effective and gave me access to my clinician or to someone who could take care of the problem once it's identified.
Sure.
That would be the ideal model or algorithm, if you will, to create that innovative tool. I think that today's group of physicians who are going to speak to you will give you a lot of information that I think will be useful, and I look forward to seeing you all next year in Melbourne, Australia.
All right. So that's Dr. Baskey's not really answering my question, but that's, if you know him, that's how it goes. But I am going to force our panelists to do that. Really, just the first thing we want to talk about is how is early detection done where you are. So, Maima, if you want to talk about that, I've got our list, and you can go over that. Up, is it on? Sorry, our microphone's on. It is now. Yeah, it's on.
Hello, it's me. Good afternoon, everyone. Hope you're doing well. Glad to be here. I'm Maima Carmo, and next February I'll be 19 years cancer-free. Yeah. Thank you. And I share it because I almost didn't get to be here. My tumor was found by myself doing a breast exam at 31 years old. My mom taught me to do breast exams at 13. To know my body early and know what to do if something changed. When I found my tumor, I saw my doctor and she said I was too young to have breast cancer, to forget about it and go home because the screening age was at 50 years old at the time. That was almost 19 years ago. And so they told me to come back when I was older and just forget about it and don't think about cancer and just live my life, right? But I knew my body didn't feel right and I pushed for mammography, which again came back clean. It was a false negative. And so if I listened to the screening and the guidance, I would be dead today. And so I had to push for almost a year to figure out, to get diagnosed with breast cancer. It was triple negative breast cancer, which is the most aggressive breast cancer you can find in women, and found mostly in black women who die, as you heard, twice more than women who are white. And so not only did I get dismissed by my doctor, but the guidance failed me, technology failed me, and medicine failed me. And as I got to go through treatment and meet other women who with breast cancer, Many were metastatic because they were, again, dismissed by the healthcare system and didn't have proper screening tools, and they were told they were too young. The screening age didn't change until this past year to 40 years old. How many women have died in the past 19 years? So it became my life mission to really ensure that, it struck me that we were getting dismissed by doctors and healthcare systems, and so finding cancer early is important. I was supposed to be here. This is what God said to me. This is why I'm still here. But I'm passing it on by ensuring women who look like me have access to tools to detect their cancers early. So Tiger Lily goes across the country and reaches women who are underserved in communities of color. And we teach them how to do breast exam, how to understand their bodies, know family history, clinical trials, but also how to know that when their body's not doing well. Because many women still aren't getting breast exams done or clinical exams done because you're told not to worry about it till they're older. So it's really important for me to pay it forward. And that's what I do every day, helping patients navigate cancer, but finding it early is truly key. Did I answer your question or no?
Well, no, but that's fine. No, actually,
you want to ask me again?
You did answer it, actually, because mammograms were the first line, right? You didn't have access to screening, though. You only had access to diagnostic mammogram.
Right.
Didn't work. And then I'm not sure, they didn't reflex back to ultrasound?
No, but I want to say that when I did get the mammogram done, and the doctor said it came back clean. I said, well, technology that would find my tumor hasn't been created yet. It's called innovation. I think there'd be a tool someday that would find the cancer early in women who look like me, or who had denser breasts. And she's like, your breasts aren't that dense. Forget about it. So I think that innovation is really key, and that's what we're talking about here: the importance of being open to tools that can help women who are younger and who have dense breasts to find cancer early.
Right. Excellent. And I think thank you for sharing your story, and thank you for starting your organization, because that's really what it takes. Just judging from the last session worldwide, that when the patients come together and the populations come together to advocate for better screening or better access, at least to be taken seriously, those are all things that empower people to do better. So I think that's amazing. All right. Joe, do you want to go? You want to tell us a little bit about your pathway to get here, and then you can answer this question.
I have finished 31 years in Tata Memorial Hospital, and because early detection, India is very low income country, and I have seen just now I have done one study, clinical breast examination versus iBreast device, and I found because I was not aware of this technology, and really it is working because I have done the 600 sample, and I realized why this type of instrument, this type of device we are not using in community, because once we use the community, because where the mammography and the sonography it's not available, only the things the ones we found any node on breast, that time that person should be navigate as soon as possible to the hospital and for diagnostic purpose. But this my 600 sample, now the analysis is waiting, but I have found with the mammography and the surgeons, and I seen the one things in my study, where the doctors who has done the 1000 clinical breast examination, they are only capable to find the 1 centimeter any node on breast. And second, this device I have seen that it's finding, and it's very easy to access. So this is the study. Once I was searching in net and I found this study, and God grace I met here in this iBreast people. That is it's really it's very good, this iBreast device, where in community level we can aware the people, and we can find out we can decrease the cancer, and the survival rate we can increase.
Jyoti, before you did the study, you were doing outreach in the community for prevention or early detection.
Yes.
What tool were you using?
Sir, we have to do a community outreach program, but our technique is so different. For the what? Because the lay person who don't understand the terminology of the medical terminology. So what we used to do, we have to just go to them, and first we are showing the PPT risk factor of the breast. After that, how to do the breast self-examination. We have to show the videos, and once they went through the videos, after that we have a manicure, and in manicure they are doing the properly breast self-examination, breast examination. So we used to do like that, and we have to tell them through social media and everywhere, just you aware the people. So outreach program we are doing like that.
And around, you're at Tata, which is, world famous, but around Tata in Mumbai even, or just outside Mumbai, is there access to screening mammograms?
Yes, sir. In Tata, we have so many branches in India. And Tata, we are doing mammogram, but Tata also is when you will see mammogram, so many, as a nurse, I know how much side effect of the mammogram, because just now I have my study, this e-poster is that the anxiety fear level of who are coming to the screening. This is in my USCC, this one e-poster is there. And I realized who has done before also mammogram, same anxiety level is there. And after also the first time who is doing same. And I have seen the mammogram is radiation, second things are very painful. So when I was doing this study, the people used to ask me, it is not painful. First question is like that. So this is the things are available in Tata, but definitely its cost, our Tata is very low cost. It's a 1,080 rupees per package. That 21 tests are free. But everyone, how the rural area to bring in Tata, it's very difficult.
Okay, so let's contrast that, or maybe compare it with Dr. Murali. You want to tell me about Malaysia's situation on the ground for screening?
Absolutely. Thank you very much, Prof. And good afternoon. Always a pleasure to be here. And so I think just to quickly differentiate, and I think just to kind of lay that out in the room, that I think we all quite conversant with the idea that screening picks up asymptomatic, lesions. And early detection, which is around what we're talking about, picks up, I think, disease in early stages when there's already like kind of more advanced kind of disease that you're looking at. And so the problem in countries like Malaysia, which is unfortunately of very little, at times it's a little depressing for us. It's a upper middle income economy, but we really don't have a policy for screening for breast cancer. Instead, our policy is to screen, this is a national policy, to pick up, go for early detection, that is pick up kind of diagnosis of people with symptoms. Unfortunately, this is the public health program, and so it runs in this way. However, civil society and private and people working outside the public health sector kind of subscribe to, I think, more the US task force kind of idea of how to do things. So we have rolled out, I think, screening early detection programs for breast cancer, a few other cancers, your screenable cancers across the country. And one of those initiatives is what the Cancer Society runs, in, which is where I work. And so to bring this back to context in terms of breast cancer, I think when you speak about early detection, Prof, the issue will be, and I think you will see this echoing, I think, across all these regions, be it a high-income country like the US or even India, who I believe is now almost in the same kind of income bracket as us. The challenge is, one, people have this innate fear, women especially, or men, within the context of breast cancer, women, that I don't want to pick up something wrong. I don't want to hear bad news. This is a kind of behavioral kind of construct that you need to understand. And I'm sure a lot of us working in this area kind of figure that out. So there's this inherent kind of push to not want to screen in case I find out bad news. That's one fact. The second problem is, and this applies both to people from really affluent populations as well as people from the lowest of the low income. If anything, we're figuring out that it actually works inverse in terms of proportion, finding a lot more people from higher income households now have a kind of bigger innate barrier in terms of fear, challenge in getting past that threshold to go and get screening, even though it can be something that's accessible to them. Now, but moving on to the middle income and low middle income, essentially you are stuck in this trap where they need to go and get either an ultrasound. We're a little bit more liberal. About 15 years ago, we decided to take a serious look at the Asian dense breast concerns. And so for younger women up to about 45, we do both a mammogram and an ultrasound. So that's standard of care in Malaysia, so both gets done. And what happens is, of course, ultrasounds are very operator dependent. And in Malaysia, it required by law for it to be done by radiologists. So radiologists, although they're not as rare as pediatric oncologists, for example, of which we probably have 5. So the concern is there's still very few in number, and they're always concentrated in tertiary centers. And you wouldn't put, I don't know, expensive ultrasounds in non-tertiary centers as well. You'd have basic ultrasounds in your secondary centers, but they're not too accessible. Mammograms are an equally difficult resource for us to kind of put out into the general population. So mobilization then becomes an issue. The ability of women to come to a center that has a mammogram or an ultrasound to get screening done, one challenge. Second is the ability of the health system to cater to these women, because primarily in a economy that's still very driven, I think nowadays, by gig economy, informal wages, and a big non-formal sector, people are losing daily wages on a weekday basis, and mostly your consultants are working on a Monday, Friday, 9 to 5 kind of process. So getting people to come at this time to screen, another barrier, unfortunately, by itself. And I go down the geographical barrier, and of course, all these other kind of financial barriers, social barriers that really are a disincentive for women to actually come out and get screening. Now, when we talk about things like, and I'm going to walk this up, from breast self-examination, there's a lot of I would say, superficial awareness around this. A lot of campaigns being targeted at women to do breast self-examination, but unfortunately, now we start testing knowledge and practice on the ground, and people are aware of breast self-examination, but they can't really do it well. Now, and I echo what Jyoti's saying about clinical breast examinations. They range between really excellent ones being done by really senior clinical practitioners, nurses, for example. I can tell you most medics are really poor at clinical breast examinations. Nurses have the time and the experience, and they seem to be much more invested in doing the job well. Reality on the ground in Malaysia may not apply to your settings. Our medical officers, however, are not doing so well at detection. And again, we ran a big retraining campaign over 2022 to 2024, training every single medical officer in our primary healthcare setting across the country, close to about 400 over clinics, the ones that are women and child health clinics. And they're not even up to about 50% are incapable of performing accurate clinical breast examinations. So they do them, and sometimes people get caught into this bureaucratic nightmare. So we have an excellent cohort of data of clinical breast examinations being done, which the ministry reports close to about 70,000. And then when you deep down into the data, you find that it's being done on pregnant or newly delivered mothers, because someone has a number to fill, and these are women coming in for regular examinations, so they kind of get a clinical breast exam, which means absolutely nothing, and it gets reported as, oh, the country has 70,000 people clinically breast examined every year. It's a joke. No, the data is real, but it's a joke in terms of what this actually means to the greater system, right? We don't do MRIs at all. And we have, I think, quite extensive kind of efforts to push people to do mammograms. We have good funding programs for mammograms. outside the Ministry of Health, and that is run by the Family Health and Reproductive Board, which funds almost close to 200,000 mammograms a year. Unfortunately, the National Health Morbidity Survey for Malaysia last year, in 2023, still reports that 53% of every woman of screening age in Malaysia has never got any sort of a breast examination, be it a clinical breast examination or a mammogram ultrasound, in their entire lives. So this is me giving you the shameful face of a failed health system.
I wanted to add to that, though. I'm Liberian, and we've been doing some work in Liberia over the past year. And one of the things that was shocking to me is that they only have about 3 mammography machines in the country. And Liberia's been going through, I left there when I was like 0 years old, but it's been going through like over a 30-year war, right? So people are thinking about, food, survival, and not even healthcare. There's no machines, a few machines in the country. They don't have enough trained staff in the country to even run the machines. 1 year I got funding and I raised money to get a machine to send back to Liberia. This is years ago. And it got stolen and sold for the parts. That's how bad things are in the country. People are trying to get to just live, right, day to day. So you're thinking about healthcare, looking at like, how do we help people who are, there's no policy around screening. There's no age or policy. There's not enough trained staff. There's few machines there. And then when you get diagnosed, it's a taboo issue. Like people don't want to touch you, or they think, what did you do bad? So, there's cultural issues around cancer in communities like that, in countries like that. Also, people don't want to hear bad news sometimes. They think, well, I don't want to know. I'll just pray it away. I'll pray it away. I'll see the witch doctor, whatever, and it'll just go away, and I'll just ignore it. And I think so when we look at healthcare screening, it's important to address policy as well, because if policies aren't in place to help people, they're not going to follow what's not there. No guidance is there. We won't have funding for trained staff, and people won't get the screening they should be getting to be able to navigate and even get diagnosed early as well. When I first got diagnosed, my parents were like, don't discuss cancer with anybody. Don't talk about it, think about it. And I had to say, well, I need to talk about this because it's important. I got diagnosed at 32 years old. And so there are women getting cancer that are dying because they're not finding it early enough, or they're finding it early and they're being told to be quiet about it in certain countries. Or if they're not quiet about it, they can't even get to like the right type of treatment. So there were some people that reached out to me 2 weeks ago from Liberia that these women had gotten diagnosed. So that's one issue. But then when they diagnose, what do you do next, right? So if there's no chemotherapy in the country, would you want to know you have cancer if you can't even get to treatment? So I think it's a multi-factored issue. Screening is so important, but then policy is important. Access to medicines is important as well. Addressing cultural taboos is also important.
That's excellent. I just to dovetail in your remark, also think about these health systems that maybe can't provide mammograms or can't provide education to their population to get screening, however it's done, and then add to them what we do when we find something. There's costs involved in that. You have to have a diagnostic mammo or ultrasound. You have to do a biopsy. You have to be able to get the needles. You need the skill to do it, and you also need pathologists to review that. So those are all added costs, not in the screening part. This is in the next part of the pathway once you found something. So you have to think about that in these health systems as well. And it makes for a very difficult problem. I'm going to skip cervical because this discussion is amazing, and we're going to keep talking about breast for a little bit. Actually, Mayma, I'm going to go right back to you. What's the journey like if you're diagnosed, late, stage 3, stage, 2.5, bigger tumor, couple nodes positive, maybe it's, either, ER negative or triple negative or something like that. What happens in the U.S.?
In the U.S., you get screening, and then you hopefully get the right treatment to treat your breast cancer. I do find that a lot of women who look like me, who are black and brown, maybe in rural communities don't have access to even screening, right? Or if they get diagnosed, they don't know what to do next. They're afraid. We've had some patients who have gotten diagnosed and they may not have a husband in the house, or they may have multiple children. So I think, we know what to do when you get cancer. We know how to find cancer and how to treat it. But I think for me, the thing about women who are black and brown is like overcoming the fear of what do I do when I get diagnosed. Who's taking care of my children and my family? Will I lose my job? And also, if you have stage 4 breast cancer, that's going to be a long-term treatment. How am I going to navigate this? And I'm going to die. If I'm going to die anyway, do I just blow it off? So really what's been important to me is getting women to know that you got to find cancer early. You have support, you're not alone. People want you to live, they want to help you navigate cancer. There are barriers, yes, but there's support for that. We all support people living with cancer every day. And so what's been critical to us is really being in the community on the ground, going into rec centers, I've been on basketball courts last summer, going to hair salons, nail salons, going into what people call the hood. You know, people one time went to do a screening talk one day. I was in, I think, Houston. And they were like, what are you doing here? Nobody comes here because it's not a safe space. People like that need to hear from us, not in just the conference center, but in places where people don't want to go. That's where people are dying the most from cancer. So just kind of like being in the community, doing outreach education, and building trust is really important.
Jyoti, can you tell me what would happen for your patient that you found with this advanced cancer at Tata Memorial and not at Tata Memorial, elsewhere in the country?
Thank you. I have worked grass level and I have seen the multiple metastasis of the last stage. And that pain, when we are seeing really, it's very bad because we are giving the morphine and this all the injections and sometimes what is happening, sometimes it's the family also not supporting. But at that stage, so it's very difficulty to, they knows very well, the patient also knows very well that now I can't survive. After that, they are fighting with their physical body. We can't express. It's very difficult because I have seen the multiple. Means all the pain is very non-bearable pain is there. And sometimes we are giving the palliative radiation, palliative chemotherapy. After that also the complications of these drugs and the radiation, it's very terrific.
And does everybody have access to that in India, or only if they go to your hospital?
So only the tertiary cancer is having the facility, all the things. And its cost is, tertiary cancer in the Tata is the cost is very low. But compared to Tata, if 1 lakh the person is paying, so outside 10 to 12 lakhs they used to pay for this palliative treatment. So because the Tata is a center government hospital.
So there's also private cancer hospitals.
It's a difficulty to take a treatment because the private, they knows very well the already life already gone and money also will go and their children who will see. So these are the problem we have. And sir, one I should mention, because when I am doing one study again, when the patient, I am working in preventive oncology, and I have seen the people are coming to us outside, so almost they refer to 2 to 3 doctors, and they spend 30 to 40,000 for the process, mammogram, sonography, and they are not finding anything after they are coming to us. That is the main problem.
Okay. Dr. Murali?
Absolutely, Doc. So I just want to go back a little bit because we have a huge staging delay issue as well. So because inherently when we do pick up something, the time that it takes between the time that you get a biopsy to getting a CT scan staging and then if you're lucky, receptor testing, takes almost, and it's so heterogeneous, it ranges between about 2 to 3 weeks in a public center, in a tertiary hospital or a university hospital. So it's excellent there. And they can initiate treatment within about 2 weeks. But at a secondary center, or even worse, a rural secondary center, can go up to about 7 to 8 months. So just that staging delay after an abnormality has been discovered on a mammogram is just ridiculous. So
and you're saying 7 to 8 months to get receptors back?
To get your CT scans, receptors, and your biopsy, kind of your HPE, your pathology, all together.
That would definitely
one person.
be a problem.
Yep, yeah, absolutely. So the huge delay there, and of course we've got swanky, lovely hospitals which are insurance covered. We've got private health insurance amazing policies that give you about $250,000 a year, renewable every year for as long as you're alive. Pay about 2,000 ringgit. What is that? About $400 per month as a premium. Unfortunately, only we have coverage of about 22% of the population on medical insurance. Everybody else, not so good. So what happens to the rest is I go to a public center, and we have now, because of generic kind of movement along trastuzumab, so people who test receptor positive on your home receptors, even if they're HER2 negative, we pretty much can give them good coverage and almost 90%, 95% subsidized. They don't pay as much, good outcomes. If you have an issue where you need Herceptin or any other kind of biosimilar, that's a bit of a challenge because we have something called, I like to call it calendar cancer. So we have a quota on our expensive drugs. So you're better off if you get cancer. If you're going to get cancer, get in January, much better month to get cancer. Yeah, absolutely. Because by the time, if you get cancer in August or September, then the drugs kind of run out. So calendar cancer. And then, so the other kind of concern, and the worst is what you're saying around triple negative, because triple negative, as you know, standard of care now involves quite extensive use of immunotherapies. Very effective, but unfortunately something that is not even being considered. So these women unfortunately get conventional chemo, if radio can be thrown at them, and then almost about 50 to 60% of the time we see them back in a couple of years with recurrence. So
I find that with people who, with black and brown patients, people are oftentimes afraid of the side effects. And, you know, I can attest to that. When I was diagnosed, not first, one time and done, I'm done. Not any calendar, not coming back. But the treatment I had was AC and Taxol because I didn't have targeted treatment for TNBC. And I will tell you, I almost quit treatment 3, 4, 5 times. You know why? It was excruciating. I would sweat, and I would have diarrhea and nausea and bone pain, and I break into welts. My entire face would be like swollen with welts in my mouth, like my whole body. And I would itch for hours. And I take 1 Benadryl and 3 and 5 and 7, and I'm like, I'm gonna die in my sleep. I call the nurse and say, I need help. I can't do this. I have to work in 2 days. And she would say, nobody else calls and complains about this issue. Now, you're always calling and complaining about this. And I'm like, I'm not complaining. I don't want to die, but I can't take care of my daughter and take care of my household and do all the things that a mother wants to do when the side effects are so bad. And so I think that, you know, we are seeing that there are more black and brown women in clinical trials, but there's not enough women in clinical trials that look like us, like me, like us, brown people. And so there's a perception, and it's very rightly so, that these drugs don't treat our bodies well. So why would I want a drug that may not help me to live longer, but it's going to cause me to lose wages, not be there for my children, and have these horrible side effects? So I think that's really important to know, and that part is not cultural, it's a fact. I mean, we have these new FDA diversity plan guide, you know, that we're trying to get more people like who are brown and black in clinical trials, but it's still not the right number of people that are in these trials. So the thing that a lot of women ask me who are of color is, if I take the medicine, am I going to live? If I take the medicine, if I don't feel good, how's my rent going to get paid, and my utilities and so forth, and also, you know, how am I going to feel? And because the quality of life is really important as well. And so I think it's important to address finding cancer early, but there's a myriad of things that are important to people that as they like quality of life. And do I take the medicine, and do I have a good quality of life for my family? So I think, again, it's important to address the main issue that we're talking about on the panel, but there are things around that diagnosis that if I do this, here's what's going to happen to me or could happen to me, that the emotional pieces of it too and the familial pieces of it that are quite important.
Thank you. I also put on the slide other countries. I don't know if anyone in the audience wants to share where they're from, if there's a story that you think is important to share about difficulties in the journey, the cancer treatment journey or diagnostic journey in their home. Absolutely.
Thank you. My name is Diana Awar. I'm a breast cancer thriver. I'm based in Oklahoma. I got treated at MD Anderson. I had a heterogeneous tumor. And what Maima is talking about, and I hope I can get to meet you after this. I follow you, by the way.
Gladly.
Is
TikTok, of course, right? Right.
you're a celebrity, you know that. And so I was diagnosed in 2020 at the height of COVID, and I had a newborn baby. I discovered a tiny, tiny lump when my baby was 2 weeks old. And that lump had been blocking the milk duct. And I experienced a situation that was related to when I was delivering my firstborn in Pennsylvania, when I believed the baby was coming, but the hospital was telling me I was exaggerating what was not there. And I've read studies for black women and maybe black men or brown people, and we are accused of, overreacting and making situations that are not serious to look like they are mountains, and they were literally anthills. And so I was literally forced, my husband was forced to sign paperwork, and before we left the hospital, it was code something, and they were running up and down and coming back and saying, oh, we are so sorry, because the baby was coming. So it comes to, there is a tumor, and it's blocking the milk from coming from the left breast. It's engorged, and I believe there's a problem. And I pump it so hard with the electric pump, and something comes out like a wine bottle opened, and the milk gushes out. I go to hospital, I was told, this is common with nursing women. And after a few days, I can feel something tiny, and I go back. And what I was told, I remember I was told I am cancer-phobic. I'm cancer-phobic. And so I went back home again. I switched about 3 doctors. And cut the long story short, 6 months down, the patient was right. After pleading with the doctor and saying, look, I believe you, because it turned from a milk duct to a fibroadenoma. And then later on, they told me, oh, this is so strange. It's growing so fast. It cannot be a fibroadenoma, and it cannot be cancer, because cancer cannot grow this fast. So this is a galactocele. And because I had a baby, and I knew I had cancer, because I'm learned, I'm a doctor of education, I've read all these things. But this happens even to the learned. And so I had to go and plead with a professional who is a surgeon and say, look, I respect your profession, but mentally I cannot sleep. And I have to take care of 3 kids. So can we just proceed with this biopsy so that I can sleep at night? And he did the biopsy, something that was meant to be a stage 0, because I know that, turned out to be a stage 2A. And I moved to MD Anderson. Now, at the diagnosis time, they said it was estrogen. MD Anderson went in, did more study of the tumor, and found it to be heterogeneous. So there was estrogen, and there was triple negative. So cutting what you're talking about in short, we have to attach culture and race to cancer treatment. And we have to start respecting all races, because some women suffer because of the skin color that they have. And all skin colors are beautiful, but we have to be taken seriously. So having experienced that, I look at the treatment that I received from MD, and it's wonderful, whole 3D. Because I went in there suicidal, because I felt betrayed by doctors that tell us, search yourself, check yourself. I do my part, then you don't do your part. And I go in, and at that point I feel like it's late. I don't want my children seeing me succumbing to this. So can you just cut this short for me? Can you just inject me so that I go? And I was so serious at that point, and I thought it was legal. But they were so good, they told me you have to see a psychiatrist. And I saw a psychiatrist throughout the treatment, and it helped me a lot. There was the psychological care, there was the treatment, there was nutritional care. I was obese. My doctor is so wonderful, Dr. Oki. She told me something she doesn't tell all her patients. She told me, you have little kids. I want you to engage workout. I need you to get to a healthy BMI by the time you finish this treatment. And I did that. I could come from chemo, rest one day, the next day I'm running on my treadmill. And all these 3 rounds plus nutrition. They had to understand what a Kenyan eats and tell me how to measure my portions and all that. Now, you asked for other countries. I later on started taking care of cancer patients in Kenya. It's not that I wanted to, but it felt that, look, you have gone through the journey and you see the disparities. I see here, I'm told what my prognosis is. A patient coming from the village in Kenya does not even know what the word prognosis is. A poor patient who you can see is at end of life is still being told, hey, there's still something we can do because cancer is a money-milking industry. So continue raising funds and bringing to the doctors. A patient who is very late and about to succumb is still told, hey, there's a doctor in India. And so there's a lot of medical tourism in India where some things happen between partnerships between doctors where you send the patient, but you know the patient is going to succumb, but there's money we can divide with this doctor from India. Now, in my own treatment, I had to take out my ovaries because of the estrogen aspect. I took all that out, hysterectomy. But it was painful to find patients who had the hormonal, but they were not given treatment to prevent their ovaries from producing estrogen in Kenya. So I went to speak to patients in a region in Kenya, and they don't even know what that medicine is. And I asked them, are you serious? Are you premenopausal? Yes. What medicine do you take? And you don't get that injection? I don't know the name of the injection, but you don't get it? No. I told them, go and ask your doctor. So when they went to ask the doctor, the feedback they would give me when I'm back to the US was, the doctor said the medicine was not available. And I asked them.
I wonder if it was, though, because you could use tamoxifen, which is off label, which is off patent. It's what is it, a penny or two a pill?
Yeah.
The injection you're probably talking about is Lupron, and they were probably talking about an aromatase inhibitor.
Yeah.
A little more expensive, also off patent, though. So
Yeah. But my point is, at least tell them.
Yeah.
At least tell them.
No,
so
I
that
agree.
if they cannot afford it, they could have another option of what I did.
Yep.
So a good number of them, 3 of them, went to do hysterectomy because this patient from the US told them about it. So you see that lack of information because of poverty makes you hold off of information without giving the information. I
Yeah.
think it is illegal and wrong to hold off information because people are poor. Just give them the information so they look for plan B.
I agree. And I
Yeah.
thank you for sharing your story. I am going to use that to pivot to my last question to the panelists, all 3 of you. And I think that you raised some really good issues about stuff we need to change. And every country, even every region, has its own stuff that they have to change or address. So I'll start. Dr. Joe, do you want to do that one first?
Yeah.
Okay.
Yes. In healthcare system, improve early detection. First, awareness is very necessary. Everyone should be aware about the cancer's risk factor of the cancer. Second, breast self-examinations. They should aware how to do breast self. And third, because if the as per this study means the CB is clinical breast examinations yearly once, but that type also doctor should be the proper doctor. And as per my study, I realized because now we are this AI era is there. And we have to change our thoughts. And in my study, I realized that this type of, if the iBreast device, which one is giving the proper idea, which I have compared with the mammogram, with the doctor findings. So why this device should use in community level, where we can survive the more people. So early detections, the 3 types of things we have to do. Thank you.
Excellent. So early detection, using AI, bringing mammograms more to the community level. I think those are great interventions. Mamo?
Oh, yeah. So I think everything you said is what I agree with that. I think we treat people, we have a sick care system, not a healthcare system. People get treated when they're sick, not when they're healthy. I think we want to change that. We say healthcare, but we don't really do that. When people go to the hospital and present with some kind of symptom, they ignore you till it's like really, really chronic, and that's a problem. So I'll tell you what I think, but I'll share my friend Shantae's story. Many of you may know Shantae Drakeford. My patients become my friends to the point where they come to my house for the weekend and I take care of them. So I love them, you know. But Shantae is a nurse and she is a ball of energy. She's so beautiful. And she found a lump in her breast at 26 years old. And she worked in the hospital as a nurse. So she wasn't like health illiterate. She wasn't blowing her health care off. She wasn't living in a rural community. She wasn't all the things people think that we do as patients. She wasn't any of those things. She knew what to do. She went to the doctor, and they blew her off for over 6 years until she had a bloody nipple. It was like dripping blood. And then she went and they told her, oh, sorry, you're metastatic. You're going to die of cancer at some point in time. She will die of cancer. And so I think, you know, those kind of things are things that pain me. There's Shantae. She's still alive. My friend Sheila found her cancer early, was dismissed for a long time, got into a clinical trial, lived for over 20 years, passed away. And my other friend, Kawana, had early stage breast cancer, ate healthy, exercise, holistic healthcare coach. I was told that she had breast cancer twice, and they told her to come back every year. And I'm like, every year you've had cancer twice? Well, many of you were at my gala, or several of you were at my gala, my Empower Ball in last November. We were at San Antonio Breast in December, dancing at San Antonio Breast. I love dancing, by the way. So I make my people dance because cancer is a tough subject, and I want to infuse life and joy and presence, right? But Kawana's boyfriend called me in January of this year and said that she went back to the hospital with symptoms. She'd been complaining for almost 6 months of back pain and all kinds of other things and was blown off. And her cancer came back, and she was dead in 2 weeks. I watched her die. I'm saying this to say that, you know, and I don't want to get emotional, but I probably will because, like, something has to change. You know, we teach people these girls how to give them little babies to understand, you know, how to take care of a baby at 16. They taught sex ed at school, but why aren't they taught about the importance of knowing their body to be able to save their lives when they're older? My mother teaching me breast exams is why I'm here today. No machine found my tumor. No, nothing. It was me knowing my body enough to push the doctors, to push against the U.S. Preventive Service Task Force, NCCN guidelines, and ACS guidelines. So I love technology, and I hope you guys meet here and me to share their tool. But nothing's more powerful than a patient knowing their body and knowing when to push when somebody else, a machine or a man or a woman, says no. Secondly, I think that we have to change a policy. You know, I got cancer almost 19 years ago, and I've been pushing to get the guidelines changed from 50 years old to 40 years old, and that took 18 years. How many women died in 18 years before the guidance was changed? Also, I have to constantly have patients call me and say they found a symptom and they have to wait because they don't have a big tumor. The thing is nothing that you're young. They get delayed in getting their screening. So I have to call the doctor and say, or text, hey, listen, get her in ASAP before I know where you live, where you work. And so I will find you. But unfortunately, the patient advocacy, like I'm literally like fielding, I have like 20 people on my phone or more doctors that I know, or more than 20 across the country, where I will text and say this patient needs to get seen tomorrow, like next week. And it's become the patient's job to navigate for other patients. And so it sucks, but what we're doing at Tiger Lily is we're building a peer navigation system where we're going to put patients who are trained advocates in the hospital so that when a patient gets diagnosed or presents with a symptom and she's blown off, we're like, we got a Mima here. Or someone like me to go and say, be a badass, push and get diagnosed. So there's things that I think that do have to change. I know I didn't answer your question. I'm so sorry.
You did.
Did I?
You
I tend to go on, but I
did.
think, you know, patient education and empowerment is key. Policy change is key. And we have to be in communities that people live, work, play, and pray in. We can't be having these conferences in these kind of centers all the time. People aren't going to be here that need to hear the information that we're talking about. So as we're having these kind of, I always say, I'm glad I'm in the room, but the people that need to hear from us aren't in this room. We got to go towards where they are. So that has to change as well. And last but not least, every single person's body is different. There's no one person that has similar issues as the next person. So like, we have to treat the individual patient as they are an individual because that's how you tend to save lives. And one more last but not least, clinical trials. Clinical trials is critical because a lot of women, even when they get to the diagnosis, the reason why they're afraid to even go through the process is that they don't want to find cancer and not get the right treatment that's targeting their subtype. And with Black women seeing their friends dying, I have lost so many people this year. People will reach out to me and say, I found a symptom, but I have a lump, but I'm scared. Having back pain, but I'm scared. because they don't know if they're gonna, when they find out, how they're gonna get treated and will they extend their life or not. So I feel like we have to really address healthcare holistically, and many of you that I know in the room are doing that, and I really appreciate you as partners and friends. But we have to do more because the numbers haven't been changing for Black and brown women. They're still dying. We're still dying at higher rates, so we have to change that. And I hate saying this now because it's been almost 20 years since I was diagnosed, but I shouldn't be telling the same story or hearing the same story that I told 20 years later. You know, we have to change what we're doing because it's not working and people are dying. So we got to do better.
Okay.
I'm really done now.
That was really last? Okay. Excellent. Dr. Morali, you're going to get the last word on changes you'd like to make. I think you've covered all the ones I'd like to make, but go ahead and tell us in your system.
Lovely. So,
One back on? You're on.
okay. Thanks. So, I think about 6 years ago, we took a serious look at all of this. And it may have had something to do with the fact that I came home that time as well. So what we did was we essentially have built something called a breast screening and early detection ecosystem. I'll walk you through it. I don't claim that it's a big success. We do about 100,000 people a year on this, but I think we continue to refine it. I'm just sharing it so it makes a little more sense, and I'm happy to take further input on this. So we identify basically pockets at the district level, and at the very beginning, we begin engaging with communities there, teachers, women who are working in civil societies, and women's organizations. With them, we have conversations around little talks, sessions around cooking demonstrations, some nutrition products, nutrition workshops, nothing to do with cancer. And inside one of these sessions, we begin to embed breast self-examination training sessions. And then we move on to actually convince them to kind of get a clinical breast examination day. So that happens a little bit like health screening day. And what we did is we invested as well in mobile hospitals. We have these things, 40 over feet trailers, which come out into the population so they can go down to smaller places. They park in a community center. Sometimes it's a temple, sometimes it's a church, sometimes it's a community hall. Sometimes we've even done it out of people's houses. And so on that day, people come, they have breakfast, there's activities for children, games, and then at the same time they do a clinical breast examination. Now we augment that because we've got a better modality now of things like the iBreast, which is portable, it's easier to use, and most importantly, we don't need to move these women from the settings. I need to tell you that in order for this to happen, all our activities happen on Saturday evenings, public holidays, and Sundays. And my staff hates me, I'll put that on, right? but we have to reach the population, we have to reach them when they're able to come, right? Next, we've even done it during weddings, so it's quite amusing. So, and then next is, once they've had a clinical breast examination, be it by a hand or a modality device, then we actually schedule them for a trip in the big city. So we actually get buses. They get, so the ones who test positive, they turn out to the big city. They get a day of shopping. They go to a shopping mall. They go and see some sites around the lousy city that is Kuala Lumpur. You're always welcome. And then they get breakfast and lunch, and in between they get a mammogram and an ultrasound. And then we send them home. So what happens is, and I told you we continue to engage these community organizations at the community level, right? So when these women come out, their children either get a movie day, or sometimes they come out. So recently we brought like 100 children out, absolutely nothing to do. But while the moms were having their mammograms, these kids got a movie in the theater. So just to kind of get them, because if no means they wouldn't be able to leave their kids and come, right? So, and once they've done with the mammogram or ultrasound, they go back to wherever they live, but they then go into something. We have a patient tracking center, just essentially, it's a glorified call center, where I call it, in the Asian setting, you call it busybody auntie. So busybody auntie Asians may commiserate with this. You always have a busybody auntie who will call you every single time and find out whether you're married, have you got children or not. So our busybody aunties, and whether you've got a better job or a better husband. What is this, our wife? So what we do is our busybody aunties basically track them over a 3-month period to move them along the needle. So if you had a mammogram and ultrasound which tested positive, they call you within 1 week to see whether you've scheduled for a surgical appointment. And if you haven't moved, can I work out to get a surgical appointment for you get a biopsy done? What do you need? Do you need transport? Do you need a holiday? Well, we work that out for you. So it's a micro solution. And after that, this woman gets on to a biopsy, gets it done, and then they go into the hospital setting. And there, as exactly as what both of them are saying, we have patient and peer navigators, who essentially are women who have lived with the disease, able to then overcome. So doctors, again, I'm probably speaking for myself more so than other professionals in the room, forgive me. Doctors are sometimes very insensitive people. So things which really matter, Dr. Ari is going to kill me after this. So things which sometimes don't matter to us, for example, like, do I need a change of clothes? Is it going to be really cold? Things like you were talking about the mammography procedure, it's really painful after. Things like this are things we never think about, but the peer navigators have been through it. They're very reassuring. They help to get the patients complete treatment, start treatment and complete treatment. So it's a continuum that seems to work for us. We can show kind of good progress. We've augmented it now by moving entirely to an education set of modules where we've produced low literacy materials, which are audiovisual, in 4 different languages, in people of different colors. So Malaysia is quite ethnically diverse. We have a big Malay population, Chinese population, Indian population. So basically, color-wise, whitish, pink, brownish, and then yellow, and some other colors thrown in. So the characters look like them, they sound like them in local languages, and that's really helped move it along the way as well. So that's been a new improvement. We've put it over the past year or so. So again, work in progress. We're hoping to get there someday.
All right, well, we're out of time for questions, so come and accost the panel afterwards. And I'll just say I learned a lot of stuff today, but 2 things I learned is as a provider, I have to be less insensitive. I have to listen to my patients. I have to listen to the populations, and I think that's a really good lesson. And I think retraining us as providers is so important. And then more importantly, we have to empower our populations, not our patients, our populations to seek the care they need, the screening they need. They need to be listened to. And those are all really important things to do at the grassroots level. And I really thank you all for attending this panel. And thank you to our panel. Let's have a round of applause.